welcome to everyone. We are going to get started. My name is Melissa Corrente, and I'm a research associate at the University of Ottawa, also a member of the Canadian Health Workforce Network. We are thrilled that you are joining us here today for our webinar on addressing health worker mental health, a toolkit, its application, and leader-focused commentary. So I am very excited to introduce the other three ladies that I will be presenting with. So I wanted to introduce you to Katrina. She is a consultant and she is from our pharmacy team who is going to be talking about workforce wellness task force that they developed to take a look at our toolkit. I also want to introduce Jelena, who's also a research associate at the University of Ottawa and a member of the Canadian Health Workforce Network. And finally, Kelly, who is the executive director of the Canadian Health Leadership Network. And we're very excited to have all four of us in the same space at the same time. If you have any questions while we're going through, feel free to pop them into the chat and we will answer them at the very end. So I'd like to acknowledge that we're gathered across Canada on territory of First Nations, Inuit, and Métis. We extend our respect to all First Nations, Inuit, and Métis people for their valuable past and present contributions to this land. I am presenting to you today from Treaty 61, the territory of the Anishinaabe, with lands protected by the Robinson-Huron Treaty of 1850. I'm extremely grateful to be able to teach, to conduct research, and to raise my family on these lands. If you'd like to introduce yourself in the chat and identify where you're coming from, that would be wonderful. So just to give you an overview, today we're going to discuss how we developed the intervention toolkit and provide a few examples to pique your interest. We'll also provide a link to the online platform so you can browse on your own and you can share widely with your colleagues. Katrina will then take you through how her team applied the toolkit to the pharmacy profession and what made sense for them. And Kelly will round out our conversation by discussing leader-focused interventions and how this can impact the healthcare system. And Jelena is my partner in crime, and she's going to be helping me talk about the toolkit that we developed with our team. So mental health care toolkit, development and curated platform. So we capitalize the word care because it stands for compassionate, accessible, responsive, and evidence-based. These are the principles that we strive to uphold while searching for resources. When we look at our project goals, our first goal was to understand the factors that facilitate or hinder burnout among Canada's health workers. According to the World Health Organization, burnout's defined as a syndrome resulting from chronic workplace stress that's not been successfully managed. Our second goal involved identifying, evaluating, and curating a set of evidence-informed intervention strategies. So my eyes, and I'm sure Jelena's eyes, are still twitching from searching academic and gray literature for more hours than I would like to admit. And then our second kind of goal when developing the toolkit is I want you to think about Netflix when you're browsing through all the movies and the TV shows that you have to choose from. When we developed the online platform, we envisioned it being a fit for purpose experience. So the different health workers, teams, and organizations could come and choose resources based on what makes sense for their situation. So much like when you're browsing through Netflix, if you like this, it will direct you to something else. So we really wanted to create a custom experience for healthcare workers. So I want to give you a front row seat to how we developed the actual toolkit. Our first order of business was to develop an inclusion criteria. So there's a lot of information out there. So our team developed an inclusion criteria to help focus our efforts. We wanted resources that were relevant to health worker burnout. So not only preventing burnout, but also addressing burnout and supporting someone who's off on a leave of absence because of burnout. So the interventions had to be relevant to a Canadian context. So although we searched internationally and at the national level, they had to make sense here in Canada. All the resources are from the last 5 years. We wanted to keep it fairly current. And we included both English and French resources or interventions. So on the right-hand side, you'll see the different topic areas. We created buckets for each topic to help us keep track of what we were finding, but also where the gaps existed. If we look at kind of an overview of the intervention categorization, Resources were placed according to the intended audience. So whether they were a worker, a manager, an employer, or an educator. We also looked at different stages. So the primary stage is more prevention and promotion of mental health. So something like a job redesign or workplace health promotion. When we looked at secondary, this is more like active training, educational programming or interventions, like more coping skills and techniques and to help with stress management. Then when we look at tertiary, this is more recovery and rehabilitation. So when we look at employee assistance plans or return to work programs. And then we also looked at different intervention stages and we looked at the focus of the intervention. So we had lots of different resources on workload, conflict management. And then for us, it was really important we looked at the level of intervention. So when we look at system level toolkits, these are more targeting policies at an association or a union level, things like collective agreements, government action, or advocacy. When we look at organizational level tools, these focus more on policies within an organization. So leadership development, training opportunities within a work environment. When we look at team level, these focus more on peer support, mentorship, and leadership within a group setting. And then individual level toolkits have to focus on worker empowerment. So changes in the work culture or aimed at leadership within a division. So we did not include or put a heavy focus on individual interventions that place the onus on an individual to quote unquote fix themselves. So we were more interested in looking at kind of the system, organizational, and team level approaches. As far as format, we included lots of different formats. So there's articles, videos, policies, programs, lots of different formats. And then we looked at different sectors. So acute, primary, mental health and substance use, and then older adult care. I'm going to pass it over to Jelena to talk a little bit more about the toolkit.
Thank you, Belisa. So Health Worker Burnout Toolkit is accessible through the Healthy Professional Worker Partnership website, along with two other toolkits, Sex and Gender-Based Analysis Toolkit and Healthy Professional Worker Toolkit. This slide is a snapshot of the toolkit platform. Health Worker Burnout Toolkit platform is accessible to everyone, not only to our project partners. We can provide a link to the toolkit platform in the chat here, so you can explore it more in detail in your own time. Please note that we are still working on it and some components will be added soon. In particular, we will add intro video as well as video with instructions on how to use or navigate the toolkit platform. We are aware that links to each individual resource might change, so we will be updating the toolkit platform on a regular basis, making sure that most up-to-date information is provided at all times. Next slide, please. As Melissa mentioned, the interventions in our toolkit are sorted according to 4 different levels: system, organization, team, and individual. So you can click on read more buttons associated with each level in the platform to review interventions at that particular level. Next slide, please. For instance, by choosing organizational level, the users are able to access all the interventions we included for that particular level. As you can see, a brief description of the intervention is provided below the title of each intervention. Each of these intervention titles are hyperlinked so that you can easily access the resource if you are interested in reading more about it. In addition to intervention level filter, we also included other filtering options, such as intended audience, as shown on the left-hand side of this slide. Depending on whether you are a worker, educator, employer, trainee, or supervisor, you will be able to select and see the interventions that are intended for you. If you are interested in seeing interventions for all these audiences, you can simply select all as an option, as it was done here. In addition to this, you can also search by focus of an intervention, intervention stage, healthcare setting, format, location, cost, and language. You can also click on sort A to Z option to see the interventions in alphabetical order. So let's say you are interested in finding more about Reach for Resilience Burnout Toolkit, which is circled on this slide. If you click on the intervention logo above the title of this intervention, which in this case is the first aid kit, a new page opens up where you can retrieve other important information related to the intervention as shown on this slide. As you can see from this slide, the first line on that new page summarizes the information on different filters or categories, which I just discussed in detail, such as location, audience, and so on. So we can see that Reach for Resilience Toolkit was initiated in the US, is intended for employers. Intervention stage is primary. It focuses on promoting mental health. It's free. It's delivered in English, and so on. As you can see here, you can also read about the evidence on which the intervention is based, including whether it has been evaluated, and if not, whether it has been offered by an accredited organization, and so on. You can also see how relevant intervention is to Canadian context, if not Canadian-based, and access other important information. As you can see, there is also a comment box at the bottom of the page where users can leave their comments related to each particular intervention. Next slide, please. Now I will showcase some interventions that we included in our toolkit. Please note that all of these examples have been included in top 5 potentially feasible and effective interventions as rated by the CPhA's Workforce Wellness Taskforce. Next slide, please. Oh, you already, sorry, go back. Okay, so the first example outlined on this slide is a system level intervention that is probably familiar to all of you. It's a national standard for psychological health and safety in the workplace. It was launched in 2013 by MHCC in partnership with CSA and BNQ. It's cost-free, and some research has shown that healthcare organizations are more successful than non-healthcare organizations in implementing the standard, motivated by the importance of building an engaged and productive workforce. Next slide, please. Transforming healthcare organizations is an organizational intervention that is basically a document that aims to help leaders in healthcare to comprehend synergies of the National Standard of Canada for Psychological Health and Safety in the Workplace and a LEADS framework, and to support them in implementing both frameworks within their organizations. Although this document has not been evaluated yet, it looks promising as it tries to connect 2 frameworks that proved to be effective in healthcare. Next slide, please. The Returning to Workplace Resiliency Toolkit for Managers provides information, strategies, tips, and resources to provide guidance to managers and people leaders in their work to support employee and team well-being and resiliency. In the toolkit, there is information and resources on various topics, including mental health impact of COVID-19, employee burnout, responding to employee grief and loss and trauma, etc. Why this toolkit has not been evaluated yet? Just go back to the previous slide, sorry. It was created by Family Services Employee Assistance Programs, an accredited organization which provides employee and family assistance programs, wellness programs, and leadership support services to some of Canada's most progressive organizations. Next slide, please. Minderma is an individual level online evidence-based intervention designed to increase resilience in high-risk workers that includes interactive learning sessions, guided mindfulness, audio tracks, videos, articles, and so on. Minderma is expert-driven and evidence-based, as it was created by bringing together leading experts and by relying on the latest research. Next slide, please. The next phase of our project is the toolkit implementation and evaluation. We are working with 3 Ontario-based work sites to customize fit-for-purpose packages of workplace interventions from our inventory. Next, we will undertake a multi-method formative realist evaluation of the customized multi-level interventions. The interventions will be evaluated based on pre-implementation and post-implementation surveys with managers and staff, and focus groups with administrative leadership and staff, facilitated by the research team. So stay tuned, as we will share the results of the evaluation shortly after we collect the data at each of our intervention sites. Thank you for your attention. I will now pass it to Katrina, who will tell you about CPhA's Workforce Wellness Taskforce subgroup evaluation of our toolkit.
Thanks, Jelena and Melissa, for displaying so effectively this toolkit, and to CHWN for facilitating this case study of how the Canadian Pharmacists Association has consumed your research. So I'm Katrina Mulherim. I am a pharmacist, and I think I find myself here today because I have an ongoing preoccupation with exploring the relationship that we have with our respective chosen work. So today, although I'm speaking to you on behalf of the CPhA, the Canadian Pharmacists Association, I'm also a volunteer member of the Workforce Wellness Taskforce. So I've been integrally involved in the work to date. So the objective for me is to showcase our use of this, what used to be called actually the Healthcare Worker Burnout Toolkit. So when we got it, it was early days, so it actually had a different title, but it's a lot more broad than burnout, as Jelena, I think, adequately explained in the new title or the new branding of this product. So first of all, a little bit about the task force, the Workforce Wellness Task Force of CPhA. We came together in the fall of 2022. There were about 12 of us, a diverse group. The task force, by consensus, decided that we would be focusing on policy and systems interventions because we realized to do otherwise would result in failure and probably alienation of those people that we wanted most to help. We also conceptualized this wellness piece as a means to facilitating fitness to practice, which would make our work relevant to regulators, employers, government stakeholders, and probably other stakeholders besides the ones that were obvious to us, so that we thought the work would be more likely uptaken. So the task force was ramping up to identify initiatives to make the pharmacy professional work life better in terms of mental health and retention within the workforce. And so we had started down this road, and then what is essentially the equivalent of like the IKEA catalog landed on our doorstep when CHWN came knocking with this toolkit. And so CHWN is not, unfortunately, a guide to complete work enjoyment, but it certainly does have broad interventions that are all about mental health and wellness. So at this point, the work that they had done wasn't organized in the way in which we've just seen in this first part of the presentation. And it was essentially a thick catalog that would probably have overwhelmed the individuals who might have come across it, especially since they were already likely experiencing certain degrees of disengagement and burnout. So we decided that we really needed to do some curation of the catalog. So what did we do? Well, we struck a group of four, a subgroup of four, and Jaden, I think, is with us today. Amy and Pav, I couldn't have done it without these other three individuals, or we couldn't have achieved what we did achieve. So we formed this team, we assigned a level. So the systems, orgs, organizational teams, and individuals. So we each took one of the levels, and we went on to develop an evaluation guide. And the guide, green, yellow, orange, red, so they're color coded, it looked at potential relevancy and adaptability of each of CHWN's interventions. So from green being the best in terms of relevancy and probably useful for many in the pharmacy workforce, and required minimal or no adaptations, all the way down through yellow, orange, and then red being probably irrelevant for much of the pharmacy profession. Oh, and I guess I should back up. When we looked at this, we were looking at it from a community pharmacy perspective, which is quite different from, say, hospital pharmacy. So we always maintained that perspective on the materials from the toolkit. And I'll also say that the four of us were from quite diverse backgrounds. And so we had hospital in there, but a lot of community experience, regulatory, academic, research, and as well as some policy background. So we reviewed and evaluated, and most of the interventions had at least 2 sets of eyes on it. We coalesced our top choices from the green ratings, and where our opinions diverged, we met to gain consensus on the evaluation. Limitations to our work, not CHWN's work. This is our work limitations. This was not meant to be a project for publication. And we did not attempt to discern the evidence that led to inclusion, and we certainly didn't critique the categorization. Our work was of low rigor, I would say, because we did not try and measure validity nor inter-rater reliability, and we did not access the resources that required funding or that simply weren't available because of moving around or defunct website type of situations. So the results. In terms of quantitative results, well, I guess I'll start by saying we looked at 140 interventions. And to achieve this stage, I would roughly estimate, and Jaden can maybe back this up in the text, but I think we probably spent about 150 hours to get it to this stage. And that included the reviewing and the meeting, and then the degree of cognitive effort, but it was a heavy lift. I guess I'll leave it at that. So out of the 140 interventions, about a quarter we classified as green. And I would surmise that other professions or organizations that are on this call today might actually find a higher proportion than 25%. The systems, we found about a third would be appropriate and potentially effective for our field, a fifth of the organization, a seventh of the teams level. Now those levels, the organization and teams, they have low relevancy, probably due to the fact that the interventions were situated within institutional settings predominantly. And that's quite different from community pharmacy. And then finally, the individual level, a full half of those would have been or are implementable. And so the individual is always the easiest level to target, so it's not surprising. And then for them, we actually couldn't evaluate. So we were really pleased about the balance to the individual interventions. And we saw the individual interventions as, yes, important, but more so throwing a professional lifeline out so that our professionals could hang on until some major changes were made through systems and organizations interventions. So this slide is a different dissection. It's according to the resource category or the topic category. And you can see that the number of interventions are skewed toward the promoting of mental health. But the following 4 categories are also very important. So the second one, managing workload, is incredibly significant in terms of its contribution to the sliding state of pharmacy professionals. And we're hearing that both anecdotally as well as in CPhA's wellness survey that was conducted in 2022, and 2023's results are pending, I think, probably in the next month or 2. The diversity of pharmacy, apparently we are one of the top, I guess, what would I say? We're one of the most diverse professions, health professions in Canada. And so this diversity means that handling conflict, bullying, harassment, and confronting discrimination merit particular focus for this profession. The CPhA, and then the final one, reducing stigma. The CPhA wellness survey suggests a large proportion of pharmacists are not willing to discuss their psychological state with their managers and supervisors. And so we do need some further research on that to add some detailed knowledge. We also need some knowledge on the pervasiveness of mental health and addictions issue within this profession. And we think that if you were to disclose an addictions issue, that these practitioners would likely experience some hardship given their proximity to substances. I surmise that this profession may be well advised to brace for increasing rates of diversion of medication, self-medication, and potentially suicide if we don't get these interventions right. So there is some urgency to this work. Qualitative findings in terms of where these interventions came out of: Canada, US, UK, and Australia. Quite a high number were out of Canada, happily, makes it even more applicable for our field. The intervention population, I think you guys kind of went over a little bit of this in that it seemed to range from specific professions like dentistry, medicine, all the way up to a general societal and anywhere in between. So in between would be clinical teams, healthcare workers, employers, and then up until the societal. In terms of the modes and media, I can recall that there was a 4-page PDF as the most simple, I guess, intervention, which was a really nice script about how to approach a colleague who might be thinking about self-harm or suicide. And then ranging up into that Mind Dharma that I think Jelena had up, which is an electronic platform that uses AI. So very simple all the way up to very sophisticated as well as very expensive. Some of the interventions did address multiple levels, stages, as well as topics, but I know that the researchers had to bucket it and make selections. So some of them could have had multiple foci. Bit of analysis. Well, there's significant resources in this space. The majority were not necessarily easily adapted or relevant to community pharmacy across Canada. As I said, probably had to do with where, i.e. The institutional setting the work occurred. There were also overtly province-specific or profession-specific products. My second point, we realized that provincial jurisdiction mattered with respect to some resources, particularly in the organizational and systems level intervention. We will be going back to look at some policy and legislation relating to employment law and regulations. We realize that there may be a high burden potential for community pharmacy managers, and that's based on the fact that community pharmacy organizational structures are very flat in comparison to large institutions or even primary health teams. So to achieve the same programming and standards for individual pharmacies would require significant knowledge, skill, attitude acquisition for managers, as well as time commitment on the part of the manager. And right now, many managers are spending a large proportion of the workday as frontline pharmacists, and they may be one of the most prone to burnout in our population. So there is, I guess, a warning there not to further overload them. We realize there's a strategy needed for stakeholder involvement, in particular for systems and organizational level interventions, given their complexity, their expense, their projected pervasiveness through the profession, and the long implementation arc. Contrasting that with a few passive educational opportunities that are deployment ready. So we're bringing a few smaller items to our professionals early on, actually this week. These things aren't expensive, they're low risk, low infrastructure stuff. Okay, so we have some high value interventions in the systems and organizational level. There are high value also in team and individual, but I'm focused here on the systems and orgs in that the first bucket of these high value interventions will require significant stakeholder collaboration. And by collaboration, we're talking about engagement initially, commitment, resourcing, adaptation. And although these are high value, they're also often the more challenging to implement interventions, but we still need to do them. And then there's a second bucket that might not need so much collaborator or so much collaboration happening, but more so that they're expensive and they need a lot of resourcing. So the collaboration there may more so be a funding consortium to get these things, to give these things liftoff. We also realized that we need a fair amount of further investigation into existing policies and programs, their pervasiveness, their quality, and their content as compared to what this evidence-based toolkit has provided for us. We need to understand stakeholder appetite to collaborate and implement. On an individual level, we need to understand the appetite for CPD or continuing professional development within pharmacists and pharmacy technicians. These fields to date have not had much opportunity or encouragement to engage in psychological wellness types of CPD. We need to understand the cruxes of disengagement, moral distress, burnout, attrition, and unfitness to practice, as well as the mirror image of that engagement. Non-moral distress, or more alignment within our workplaces. And if we don't understand the cruxes, then we might be hooping ourselves, i.e., the likelihood of effectiveness of these interventions is vastly decreased. And then we would also need some outcome monitoring, especially given the expense and resources that some of these strategies will be taking. So why the toolkit may not be as transferable into community pharmacy? Well, actually, I'm going to start at the bottom here, because I think this is the most important and really lies at the basis, I think, for this lack of maybe transferability. And that is that the pharmacy profession is largely absent from programming and research. And that really needs to change. The next one up, we saw there were limited interventions targeting workload management. As I mentioned, we see that as a very important piece of the puzzle for pharmacy. The research and interventions were situated in institutions. That means that the work may have been less adaptable to community pharmacy workforce, and it required significant redevelopment and research, or will require significant development and research. CSHP, the Canadian Society for Hospital Pharmacists, will be interested in this, no doubt. We see a lot of applicability to hospital pharmacy. And then the top point, the setting of community pharmacy is commercial in essence. And so that means that the workers are susceptible to interruption and much less control. Geographically, they are separate from the care team. And intensity-wise, the volume of patient-professional interactions is high. Pharmacists and technicians come into contact in some pharmacies with hundreds of patients a day. In terms of management or upper management, it is either remote or doesn't exist in small independent pharmacies. So next steps. Well, we've finished our top 5 interventions for each level. We reconvened with CHWN in the winter. And now we're in the final development phases of our intervention implementation plan. As a part of that plan, we have some light implementation plans. We have multiple large projects, and we are setting out a research agenda. And then we're going to work the plan. And as I've mentioned, to coincide with CMHA's Mental Health Week, which is this week, we've got our first release coming out, and we will be looking for some research project funding. So there's a long but interesting road ahead of us. A few reflections. We're really appreciative of CHWN's production of this toolkit. It was timely, it was evidence-based. It gives us the basis for good decisions in terms of interventions, rather than accepting the suggestions and proposals of who comes knocking at an opportune time. As far as tips for our, I guess, viewing population here today, I would ask you what your field's evidence is with respect to disengagement, moral distress, burnout, attrition, and fitness to practice, and consider that as you review these interventions and make your selections. And that will make sure that the work is relevant based on the cruxes of your evidence, and then you can figure out how you're going to adapt it. Don't underestimate your evaluator background or professional role. It matters to what is selected. And then I guess I would say we've gained 6 months by this toolkit landing on our doorstep. We have also gained quality because we never would have managed the comprehensiveness or systematic approach that CHWN has. And it's given this plan, I'd say, much more confidence to move forward. And I watched the Fred Rogers documentary yesterday, and so I went looking for an appropriate quote. And I thought this one apt. There is no normal life that is free of pain. It is the very wrestling with our problems that can be the impetus for our growth. I think this toolkit essentially helps us with the wrestling. Thank you.
Thank you, Katrina, for that. Awesome presentation. I loved your curation of the IKEA catalog, and I do think it's something that health leaders need to do as well. So thank you for that. When we talked about the setup, we talked about maybe having a filter for the various professions, and I can really see that we could do this going forward. So I am Kelly Grimes. I'm with the Canadian Health Leadership Network, and if you're not familiar with us, we are a non-for-profit network like CHWN is of 40+ healthcare organizations. We go coast to coast, and we're all about building health leadership capacity and capabilities and finding the new leadership practices for 21st century care. So as the pandemic showed, these are starting to evolve as going forward. So have a poke at our new website, www.chlnet.ca, and have a look around, because there's a lot of interesting and free tools for people going forward. So before I jump into my leader focused commentary, I want to talk a little bit about the work and how this fit in with the work that we're doing. So during the pandemic, we did a whole bunch of focus groups and aggregated data from what leaders, focus groups and interviews of leaders across the country on what they were feeling in terms of leadership challenges and what their experiences were. And not surprising, you can see in wave 4, leaders went from being superhumanized to being dehumanized, and fatigue, chronic stress, and moral distress were huge for leaders. So when we saw that Ivy and Melissa and Jelena were doing this toolkit, we were like, oh, fabulous, because now we have something that leaders can actually access. And I'll give some more comments on that going forward. So what we found from this leading through COVID, and there's a couple of publications on this, so you see them in the lower corner, so feel free to have a look at them, and again, have a poke at our website, there's some more as well. And so 2 big things we found is that leadership matters for adaptability and learning, and that there was a huge need to accelerate 21st century care leadership practices. So we looked at the internal and external challenges that the pandemic presented and that still present going forward. And you'll see the top 3 were around EDI, indigeneity, and reconciliation. And a big, huge one was around the human strengths and limitations. And leaders were telling us they needed tools and techniques around supporting the whole person, compassionate leadership, building resiliency, psychological health and safety in the workplace, those kinds of things. So when we saw that this was happening, it was a huge boost for our partners, and we'll be sharing it going forward. Just a few other musings on this, and I loved what Katrina did in looking at it from a pharmacy perspective, and I think that we'll do something similar for our leaders and look at building that filter for leaders going forward. Our value network is very much at that system organizational level, and so that's where we'll focus rather than the team and individual. It's presenting a living and breathing toolkit with regular updating. And that's really of interest to CHLNet because we've created some toolkits, some with Ivy and team already around Empowering Women Leaders Toolkit project. And it's hard to keep these things going and building them all the time and looking at new evidence. So I'll be watching with great interest to see how you guys continue building this going. Our leaders also, they have crazy lives. There's so much going on all the time that this one-stop shopping is huge for them. So by allowing this one stop that they can come in and it's curated, and we will look at doing that, as well as research that Katrina talked about. I think there's some more things that we've been doing around research and leaders' involvement, and because leaders play such a big role in impacting the culture and the psychological health and safety of workplaces. And so what's missing for leaders themselves? I have to say, I don't know. And Ivy is going to be presenting to our network partner roundtable on Wednesday. And we'll be doing a little focus group and hearing from leaders what is missing when we're going through. And we will do some more conversations on this going forward. But again, nice work. Thank you for this. And I'm very happy to share it with our 40+ network partners across the country. And Katrina, pharmacists aren't around our leadership table, so we should talk at some point because it would be great to have you guys there. That's it for me.
Thank you so much, Kelly. So I just wanted to thank Jelena, Kelly, and Katrina for joining us for this webinar, and we appreciate everyone who came to listen.